Rahim. So I have no conflict of interest. That will be my outlines. We all know that the afferent and efferent arteries have effect on hypertension and they increase the hypertension mediated organ damage. There's a lot of 15 years, there are different trials, sham control and non-sham control, which lead to the renal denervation consensus by EAPCI with class 2A guidelines that an adult patient with uncontrolled resistant hypertension already being discussed with 140 and 90 millimeter Hg, which is confirmed by the ambulatory BP, and treated with 3 or more than 3 antihypertensive drugs, and the eGFR is 40 or more than 40 ml per liter. This is class 2A recommendation for renal nerve denervation. There are some class 2B recommendation when the patient can't tolerate the drugs and those who prefer to be treated by RDN by shared decision making, and even if these patients are less than 3 drugs. Now all these indications being proved by almost all of the societies worldwide. So if we remember the indications, the RDN, the resistance, the hypertension mediated organ damage in the non-adherent patients. So there are 3 types of renal denervations. One is spiral multi-electrode catheters, the Paradise focus ultrasound renal denervations, and the alcohol mediated renal denervation system. So nowadays which is recommended is the radio frequency renal denervations being manufactured by many of the companies, but the simplicity trial being conducted by Medtronic. They have generators, they have the electrodes, and there's basically from the femoral root. So these were the comparison of the 3 renal denervations, and we can see that the frequency have long and short-term safety as well as efficacy. So before going for the procedure, imaging is important. Which imaging, CT or MR? So they've prepared the CT because to exclude the secondary causes and for procedure planning by the accessory arteries, devices, angulation, all these things. CTA is important to measures and to look for the accessory arteries, and abdominal aortogram is the gold standard. So how you perform and where it should be taken and why. So it basically is very simple, 5 to 6 French pigtail catheter by the simple 0.035 wires and 10 to 20 cc of contrast. The views will be 1 to 2 lumbar vertebra, AP or LAO 10-20 views. Why? For renal arteries and for accessory arteries. For its size, take-up, course, toxicity, and all these things should be taken in consideration while doing abdominal angiography. You have to selectively take the renal angiogram to look for the size, take-up, course, and tortuosity. That's how you plan for ablation, and procedure-related concerns will be taken. If you look into this is of the same patient. You can see 3 of the different arteries of the same kidney. They are accessory arteries. So when you do the renal denervation, you have to look for the accessory arteries. If you didn't ablate all the arteries, it is unsuccessful procedure. It is very simple. The procedure is very simple. You assess the renal anatomy. Then if the patient is treatable, then give medication for conscious sedations, plan your treatment areas, and insert the guide wire, advanced simplicity spiral catheter, and deploy it. Treat distal to proximal, starting with the branches followed by main renal arteries. And once the one-sided artery is done, go to the other artery and treat it. We can treat 3 to 8 millimeter of renal arteries, and for main renal arteries there is usually 2 to 3 emissions, and for accessory arteries only 1 emissions. But you have to remember that you have to keep the catheter 5 millimeter if there is stenting, if there is bifurcations, and if the artery is less than 3 millimeters. This is the generator, that how it perform, and you can select any of the electrode or 4 of the electrodes by denervating the renal artery. Some of the side branches are tortuous and angulation. It's very simple, like you are doing the coronary artery, so you have to proper guide wire selections. The body wire can be used, workhorse wire, and then exchange with dedicated wires. And sometimes the ancillary devices like microcatheter and guideliners can be used for the tortuous arteries and angulation. If we talk about the major adverse events, this is the safest procedure. You can see your there the 30 days events is no significant events occurred in the simplicity trials. Now coming into the conclusion, renal denervation is a relatively straightforward procedure. It's not only safe but also effective. Based on high hypertension prevalence, in futures, RDN number will be overwhelming for catheterization laboratories, and RDN should be performed as a day case procedure. It is important to adequately plan for indicated patient and prevent complications. We are about to start the procedure next month, inshallah. All the patients have been screened for that, and we will planning to do 5 cases in Pakistan.